Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This week, I am with Nick Zuber. Nick is a PhD paramedic. I met him in Gunnison, Colorado, on a Sean Keenan PFC course. Nick, welcome to the program.
Thanks, Aebhric. I'm super excited to be here.
So you've impressed me in what you're doing in remote medicine, but tell the listeners a bit about yourself and who you are, where you come from.
Absolutely. This is one of those questions I honestly hate answering. I don't like talking about myself. I grew up in the Washington, D.C. capital area region, and I got, involved in pre-hospital care and public safety like a lot of people. I started as a volunteer in a really great combination department, Fairfax County Fire and Rescue. That's where I cut my teeth. Learned a lot there, learned about, what American traditional suburban kind of 911 looks like. And I got into the ALS world by accident. I had zero desire to be a paramedic, but I actually got hit by a car, and part of my consolation prize was, hey, you're probably not going to be a firefighter. Let's send you to intermediate school, which was
Wow.
the high-level ALS there at the time.
Wow.
And here we are an FPC, and 20-something years later, I fell into just increasingly more challenging and more appealing levels of pre-hospital care. So you and I had a mutual friend for a long time, Dr. Keith Brown,
Yep.
who I met through the internet years ago, and he took me under his wing. Like, I knew the right people at the right time, and I think you and I, knew each other through emails and stuff
Correct.
for years.
Yeah.
And then you showed up on my front step one day, where I ended up working in the middle of Colorado. But in terms of what developed me in the remote world or the austere world, it was more than anything because of Dr. Keith Brown and his courses. That at that time we're in Belize. I didn't know a whole lot. Everybody's got those dreams as a paramedic. Oh, I'm going to fly. I want to do this. I run away and do this other thing. Him and his group were the people who were like, do it. Everything's a test with Dr. Brown, and that's okay. Once you figure that out, it was a great thing, and it completely changed my view and paradigms on what we can do here in the States even, and a more traditional ambulance service, and just do better patient care. Belize that those courses were absolutely life-changing.
So for the listeners out there who don't know about Gore Group or about Dr. Keith Brown, go ahead and give us an introduction.
Yeah, so that man, I think, is a quiet powerhouse in the industry.
Indeed.
I would say one of the OGs, but he's still there. He's still doing medicine. In the early 2000s, he had this program in Belize with some others where it was generally a month-long course, and it was full immersion. They ran it like an expedition. I learned the phrase "dinner may be late," which I still use today as a leader. That's just how it is in the reality that we work in, and if you always viewing things from that flexibility. And so this course was a remote medicine, austere medicine, that course that was focused around operations as well, which is huge in this world, right? It's easy sometimes to just want to do good medicine, but when you have to move people and deal with logistics and be able to pivot, that's huge. I think that kind of paints and colors everything we do in the remote world. And if you don't figure out how to think that way, you're going to have a hard time. And so they taught a lot of that. So we would live in a camp, and there was camp duties, and we did everything from being in the jungle and working with the local Belizeans, who are just amazing human beings, to go into local clinics and managing operations that way. So it was often a 24-hour drink from the fire hose, but very student run, as in you are part of the team and you're going to figure that out. You're just not being fed academics. And that's, I think, I loved it.
Yeah.
There was challenges. I still remember we had set up some rope rescue thing, and we did everything, and we were really excited about this system we were going to use to uphaul this patient, and then the velociraptors came and took our ropes. And it's like, okay, I could smell that scenario still. And that's what happens in real life, right? The trucks break, the helicopter gets canceled, you forgot to restock the bag, the patient got sicker, or the family member shows up and you don't want to go, and you've done all these plans to get somebody out of the back country or something like that, and then you've got to pivot.
Mm.
Um, and so that was Belize. I spent some time in Greece with him as well, doing a tactical EMS class,
Nice.
and eventually ended up working for him with Gore Group, which went overseas. We were in Iraq. I was there for just under 3 years on 2 different projects as a medic,
Wow.
working with people way cooler than me. The imposter syndrome is still real. Uh, but that is the very short way I got into remote medicine. You know, I came back after the Middle East, and flew for a little bit, was on a Thames team, somehow made my way from the DC metro area here to the mountains, of mountain America, which is very, very different than when I grew up. I grew up next to big airports and, diplomats, and now the closest Target's an hour and a half away.
That's where you and I met. We met in Gunnison, and we were running a
Hmm.
Austere emergency care course with Sean Keenan. And I was, well, to say impressed is an understatement. You and your group have created a world class city based, town based EMS system, but doing remote medicine, doing austere medicine. Your commute times are hours, and you're using a lot of the learning that Dr. Keith Brown gave you. So tell the listeners a bit about the awesomeness that's happening in Gunnison.
Yeah, so Gunnison, Colorado. If you find it on the map, it's kind of in the middle of the state, but a little left and south of the Continental Divide. Um, it is a river valley, so we've got everything from the ski slopes and stuff onto the high end to, high altitude desert and rivers down on the lower end of the county where I live and where our station is. We cover plus or minus 4,000 square miles. We are a government based critical access hospital and a service that works for them. And so, the kind of put things into perspective, the closest cath lab's about an hour and a half away.
Hmm.
The closest level 2 is about 2.5 hours away, and the closest level 1's about 3.5 hours away. So we have this weird mix of the inner city, if you will, urban problems, just like you would see running downtown everywhere else, and in an urban environment, and then these kind of wild back country and side country things that happen, and then everything in between. Because just getting to somebody sometimes is an hour long process.
Hmm.
Um, and so I've been there about 7 years, and it was always a good service, and we've really pushed going to become a great service. We really looked hard about where we're failing and what we can do better. With our new chief, who started right before me, CJ Malcolm, came from a park services background, and we just knew that flights often don't come. They're down for weather all the time. And I think in the austere world, even in this world, if you plan on flights working, as you often mention on this podcast, you're going to have a bad day too, right?
Hmm.
And so we decided, where can we push the envelope? We were the first ground agency in the state to have blood. Um, we
Excellent.
have right now a unit of plasma, fresh plasma, not frozen plasma, and a unit of packed red cells, and hopefully we'll have whole blood here soon. The state has a task force and a coalition that's really pushing that, and that's going to happen.
Nice.
Um, and we leaned in hard to what we call all hazards, right? And so our whole concept, whether that's a call in town and it's just for like your run of the mill abdominal pain, or we're way back up in Tin Cup where some people live all year round, where you have to snowmobile in because that old guy is going to die in that cabin no matter what, right?
Hmm.
Um, I want to bring the highest level of medicine to that patient, wherever their point of injury is. So that really kind of follows that TCCC and that prolonged field care stuff that the military is doing, and that's why like Sean's course, which we're doing again here in March,
Nice.
is amazing for us, right? And so we can bring labs to this patient. We can have a good ventilator. We can have critical thinking. I really think, people always harp on that, and it's kind of a low hanging fruit in terms of a term. But if you can paint that cultural picture that your providers can think through these things, and there are options, and you go beyond it's wilderness medicine, so we're just going to kind of improvise everything, we can have higher standard levels of care. even in America here in remote places, or as you would in the bush in Africa. We could do that, and I think that's really kind of modeled everything we're trying to do right now. We don't always nail it, and I think that's part of it too. Is you got to understand, you know, it's time to face the hard facts sometimes, and what are we not doing right, and figuring that out as well.
So you have not only pushed the envelope on the clinical side, you've done a doctorate in emergency and disaster medicine, which is impressive. So tell us about your academics as well.
Yeah, so academics. I besides not wanting to be a paramedic, I never wanted to go to college. I also got lost. I did my undergrads in health sciences at George Mason University there in Northern Virginia. Um, and I remember being young in public safety and really legitimately having this kind of ethical dilemma with the people, in the swivel chairs that made the policies and the people on the ground. And I could never wrap my head around why policies um, were so different from the reality that we would face
Hmm.
on the streets. And so I ended up getting my master's in emergency and disaster management. And that was really brass tacks of that world and that industry. And I ended up getting my doctorate, which is very driven in, is this policy good? How can we make changes? The statistics of things. And that is, I think, what lets you sit at the table, right?
Hmm.
EMS still has a lot of people here in the States that make decisions for us that are not paramedics at every level, right?
Yeah,
And so that was huge for me. What can I do to sit at that table and earn a seat at that table? Um, and so I did it. It took way longer than I wanted it to. It was a lot of really late nights and typing a lot of papers. Uh, but it's something that I legitimately use all the time. You learn better how to better communicate, being able to say, here's the data for this problem, or here's a model that's worked somewhere else, or, you know, I read this thing at this other place. That we can apply here. Let's see if it works. Uh, so it's been a game changer. Really, it has. I mean, you've got to decide what kind of level of work you want to put into this, but to be able to say, hey, we're going to really think about this problem, we're going to fix this problem, and we're going to use these metrics and data and come back and measure it and see if we fix this problem, I think is just really something that I enjoy. And that's why, going to grad school and applying that to um, a type of industry that often education is getting better, but people don't really get into that higher level of education as I think they should.
that's true. But there are getting more and more doctoral level paramedics on both sides of the pond, and you're now leading that charge of trying to get the paramedic industry a degree oriented. I won't say degree based. I don't want to start a whole conflict about bachelor's level paramedics or not, but you are pushing the academic side of EMS, which is needed profoundly.
Yeah, and I remind people, I think a lot of people as younger paramedics here in the States, they do that associate's of bachelor's and they just don't have a good time with it. So they get really turned off to the graduate level education. And if people take nothing away from this, I think if you go get that grad education, grad school's so much more about what you want it to be and
Mm,
being able to like really mold what you want to study and things that are important to you and that are passionate to you. If you're a paramedic that's like, man, public health was huge and COVID drove me crazy, we've got to do it better next time, you can do that. If you want to dive into more clinical things, you can do that in grad school, I think, more than you can in your undergrad.
indeed.
So that's my biggest thing I tell people, right? Is it's not your undergrad experience. It should be better. Give it a chance.
And as an academic, dealing with master students is so much easier than undergraduates because they're self thinkers, they're self motivators, they're kind of going in a direction, and you just got to give them right and left limits a bit. Where the undergraduates, you kind of have to spoon feed them once in a while and get them up to that level of thinking of a degree paramedic, and it's a challenge, definitely.
Yeah, I said earlier, it's that building that critical thinking, right? And if you teach people how to find information, how to synthesize that information, and make a decision, and you build that comfort where I'm going to make this decision after you've gotten all this pushback from your professor, let's say, and then they're like, yeah, you passed, right? It's building that model and that convincing thing, and I think that echoes all throughout what we do, because it may be that simple 911 call or that big, backcountry call, and how are we going to evacuate this person, or I want to bring changes in my department. Here's a paper, here are the statistics, here's where people failed, here's where people succeeded, and here's why I think it's going to change things and do better for my patient population.
Mm.
And that, you can learn that, obviously not going to college, but I think that's where you kind of hone it and refine it, and you're just kind of forced to do these projects and talk to people you wouldn't normally talk to, and therefore, you sharpen that iron when you have to do that.
It definitely makes you think differently. In grad school, having to do all of the big picture thinking of not just, all right, how do I, what drugs do I give? It's why, and more importantly, population level of why. And then with your doctorate, now you're thinking global level, at a 1 to 250,000 view on EMS, and well, for yourself, it's emergency disaster. Like, so what direction does this need to go? And you're pushing on that now.
Yeah, um, everybody who knows me is going to cringe when I say this, but systems thinking, that is the most important thing I learned um, from grad school, and that my doctorate is, nothing happens in a vacuum, right? And I think most of us kind of realize that, but we can do 1% changes in those patient populations and make big changes overall, right? That's why
Mm.
public health really drives EMS. If think about all the calls you hate running is a normal urban or suburban 911 paramedic. What can we do to stop that? We know better public health might keep me from running toe pains at 4 a.m. I really think that's a
Mm.
thing, and that's education and policy, and it's moving us forward as EMS providers too, right? If we're making our own decisions and owning our problems and finding solutions for those, it's probably always better, if not, always better, coming from us versus someone else who's not in our world making decisions for us and how we do things.
Mm.
And we have to be educated to sit at that table and create that change.
And academia allows you, trains you, gives you space to think that way.
Absolutely.
Yeah.
It's building mental models. It's, we all, I think most of us learn the scientific method in elementary school, and that's like a basic mental model, an academic model. Let's bring that further. What does, a program evaluation look like? What does action research look like? You can do that. Paramedics doing research these days are absolutely taking off. It's amazing. You
Mm.
see your friends' names on these papers and stuff. But we're doing those in environments. How many airway studies have you read, Aebhric, where it's done in a lab, but it's a pre-hospital airway study,
Yeah,
right? Like, that's not the environment we work in. There's
no,
way more variables than that. It's
definitely.
cold, it's hot, you're getting attacked by the chihuahua, you've got to move this person down all these rocks, and you're going to run out of oxygen because you didn't plan ahead. That's the reality that we work in. And so much with like other research, if we're not doing it in that reality with people that understand that reality, it's just not as good, right? It's going to always miss a mark, and then you're trying to figure out how to apply that.
So, Nick, tell me a bit about your remote clinical practice. Tell me about one of your more interesting cases in prolonged field care.
Wow, there's a lot. I think the overarching theme is, I don't know what I don't know, um,
Mm.
and that I always need to be more curious than I think I need to be. Uh, an American paramedic is not prepared to do the primary care that you think you are. I mean, it's simple stuff. When I was working with a lot of the Ugandan guys, totally different culture. I'd never worked with them and understood them until I was there. And so just a lot of primary care stuff where basic things like, hey, they've got this viral illness that you don't need antibiotics for, and things like that. But then it's just like you see in a lot of places, I need antibiotics. So they find that on the market, or they're self-treating. It did not happen at my camp, but I was helping one of my buddies with this. They had a chickenpox outbreak in the guard population, and chickenpox in America is no big deal. Everybody has it.
Mm.
I was of the era where you went to the chickenpox party, right?
Oh, yeah.
And everyone got it. Mom made sure you had it. You sweated through it, and then everything was done. But now we had this whole population that didn't want to be isolated and quarantined. Um, and you had to figure that out. And so it's not heavy on the clinical medicine, but the logistics and the operation and the thinking how we're going to do things, that was huge. What do you do with these guys? You don't want to evacuate them, right?
Mm.
But you got to keep them away from everybody else. And it's this huge international population that we think maybe we know vaccine statuses for, but we probably don't. um, to things, here in Colorado, I had, we often get very seasonal activities. So we see a lot of trauma based in the summer on four wheelers and quads and dirt bikes, and in the winter, snowmobiles, and people like to do that in the side country, in the back country, right? More accessible than ever. Um, because you can get your spot beacon or your other GPS beacon and you go out, you feel safer. You see these things on the internet, on YouTube, and you're like, I can go do that too. And often these people aren't prepared. I mean, even recently, we got call for the Taylor Park area, which is about 30 to 45 minutes north of our station. Beautiful wilderness. There's a little trading post up there. It's already, early in the season, snow covered, icy, and people are up there on their sleds or their snow machines, right? And I had no idea. People rip on those 50, 60, 70 miles an hour in one of those. Maybe I'm getting old, but no thanks.
Yeah.
And you have that trauma patient up there, and everything starts with our dispatch, right? And so it's just like, oh, minor facial injuries. Okay, what do we bring? Do we bring blood? Do we start front loading that? And one of the things we do with those calls is, it's easier to push those resources early instead of trying to pull them later, right? And so bring all the things, but don't bring too many things because then you can't move. And we send an ambulance, and we have a vehicle it's a backcountry vehicle that we can move with. So we get up there, and the dispatch was totally benign sounding. I wasn't even going to go as the shift supervisor. I had a super competent crew. Um, and you get that hanky feeling when you've done this for a
Mm.
while. It's, that the hairs on the back of my neck, something doesn't sound right from those two sentences from dispatch, or, when someone comes and tells you something bad's going on. So I ended up going after some hemming and hawing, and they had requested me because we weren't sure what the roads were like. And so 45 minutes to get there, icy roads, weather's questionable for the day, as it often is here in the mountains. It's the classic, if you don't like the weather, wait 15 minutes and it'll
Mm.
change. Um, and our flight agency that we work with the most, it's got about a 55-minute flight time in a helicopter. So it's up there on a good day. And so that starts this call. We get up there, and I'm talking to the patient's already in the back of an ambulance. He's there. The husband's there with a sled. There's kind of like blood all over him, all over the sled, all over the snow. So it's really easy to see. And I'm like, I still don't know what's going on. And this guy's really upset. And I just hear the yelling in the back of the truck, right? And he's like, "Oh, we got to do something. Can't you give her something?" I'm like, "Oh, sir, I'm sure she's fine. We just got to give her some pain medicine." Kind of downplaying things. I
Mm.
had no idea what's going on. I get inside, and this poor lady who was helmeted sounds like she lawn darted off the front of her sled onto the icy, packed road.
Oof.
It's got a foot of snow on it that's hard packed, head first, helmeted, but head first. So she's got a lot of tissue trauma and clearly has a closed head injury, right? And in itself, not an uncommon thing. We see that all the time, but we're 45 minutes to an hour from my critical access hospital, who 100% is going to send her out no matter what.
Mm.
That's just is what it is. There's no neuro there. We don't keep people with like that. She's going to probably get a head CT, maybe some Keppra, for some seizure prevention, and then my crew's going to have to take her somewhere else. So we were late into the game and ended up requesting flights, which means I've got an hour to kill. But the thought process is we're going to get this patient to where they need to go the first time right away.
Mm.
Um, it's easier on the patient. It's easier on the hospital team because they don't have to go through the process of getting someone transferred, which we're still digging out of, dealing with, through COVID. There's beds and staffing issues everywhere. And so sometimes, these docs or ER docs end up shopping around trying to find someone to go. But if they go from the field, it's like me and my ambulance on a 911 call. So they get to go right into the system.
Mm.
Um, and she was the combative injury. So you sit there and go, what do we do? Sometimes the answer is just RSI this person, but then they're on oxygen. What are their oxygen and sedation needs? versus waiting to make decisions, and how we're going to manage this person for the next hour, which in a lot of America, an hour as a paramedic is a long time, right? It's a really long time.
Indeed.
Um, and so that I love. It's the thinking game. One of the biggest changes I think we have pushed in those worlds is really getting into infusions versus just push dose stuff, right?
Mm.
Because I can manage my patient's pain or sedation better, and my medicine lasts longer.
Right.
And so when people are like, "What are you doing there in Gunnison? That's really changed things," and um, if it's a remote place, I'm like, talk to your medical director, get competence with, and demonstrate that we can mix these meds and get a pump. Um, hills I'll die on in EMS that I deal with all the time. They're like, well, we're paramedics, we don't use pumps. It's like, you're not better at counting drips than anybody else. Um, it's a cognitive offload. Make your life easier. They're not that expensive anymore.
Mm.
They're easier to get. They're easier to use. Use a pump. I mean,
Indeed.
think about it. If I mix that fentanyl and do that, or I intubate this person and they're a ketamine infusion, it's way easier than me having to deal with every 25 minutes, every 30 minutes. Oh, they're waking up, their RAS score is bad, they're uncomfortable.
Right.
Now I'm uncomfortable because I'm drawing up meds. Put it on a pump. I think we've got to get over the ego. There's no shame in saying this calculator is smarter than me, because I know it's smarter than me.
Right.
Um, and so she had a combative head injury, a big ocular injury, and we ended up not RSIing her because, to me, the reason to RSI her was aircraft issues. So most people out here fly A-Stars, which are they're good performance at altitude helicopters, but it is the Honda Civic hatchback
Mm.
of the HEMS world, and there's not a lot of room. And the flight medic that day was probably 6'2" as well. So that airway chair for the patient, you are straddling them for the next however long a transport is. And
Mm.
I was like, hey guys, here's what I think. What do you think? I got everything drawn up. What do you want to do? And again, it's that decision making process. And they were able to take her. They ended up RSIing her because of aircraft issues. An awake patient in an A-Star that can reach the rotor brake is not a good day for anybody.
Indeed.
And we sit back, and part of those longer transports, because we were up there for almost 4 hours with this patient when it was all said and done, right? Her injury was 4.5, 5 hours before all of this, and she got evacuated. That's a long
Wow.
time in the
Yeah.
US. But that's not abnormal for us. I don't do it every day, but it's not abnormal. We had a plane crash this summer in the backcountry, a small Cessna, 4 people, burns, bad access. And
Oof.
so we know what to do for the medicine for those people, right? We know how to treat burns. It's all about moving them and getting to them. And so part of one of the things we've done to really front load our mass casualties here, knowing that this is a giant system and we have to move people through it, and the 911 calls don't stop, and the hospital wanting to send people out doesn't stop, and the mutual aid request to go somewhere else doesn't stop, is we put a captain or leadership at our station. And it sounds like a really boring assignment, and it's not clinical, right? But being able to talk to hospitals and manage staff as they come in and out, and um, help have a plan or move supplies to that point of injury is huge.
Mm.
Um, they flew a bunch of people out from that went to the burn center because they had a fair amount of burns, but everybody's doing well. And again, the after action is the most important thing. Hey guys, what didn't go well? Let's really talk about it. Those often the first answers, communications, right? Everyone's like, oh, the communications weren't good. Always an issue. But where do we improve on those medicines, and then medicine and the operations, and having follow through? Follow through is hard. It's tough, but hey, we got to change how we do these bags. They just don't work for a bunch of these calls. It's not just the one off. And then going back and evaluating that, this failed, or we're carrying too much gear, or we're really, you know, we people have to go to the bathroom all the time on these 3.5 hour transfers, right? And so we ended up getting those new PureWicks, and those are game changers.
Nice.
Have you seen those before, Aebhric? The new
I
PureWick
have
that's out?
not. No.
Yeah, so it is a device usually for women to use the bathroom. It goes up to your suction, so it just kind of goes down where it needs to go, and people can go to the bathroom, and it goes right into your suction on your truck.
Nice.
Um, yeah, it's fantastic, and that doesn't sound sexy, right? This is not remote care. It's not this amazing austere rescue, but it is this prolonged care where instead of someone sitting in a diaper for 3.5 hours and then getting to the hospital and them catching up to change that patient, I have not caused skin breakdown and I've not added to their discomfort. And it's that little 1% change, I think, that really helps my service, and it can help any service because it's not hard to do something like that. Build its extended care and prolonged care tactics.
Yeah, I just pulled it up. I've never seen Pure Wick, but it's clever. It's a clever bit of kit.
Yeah. And it's the super simple thing.
Now I'm trying to figure out how can we improvise this.
I've seen some people. I'm sure someone's rigged out there. I think I've seen one, but I'm sure you can make something up, right? I mean, the physics, understanding that basic model of what it is, right? It's a suction device,
Hmm.
right?
Yep.
How can we make something like that where we don't, otherwise have it? I know, you know, prior to the Ducanto suction catheter days, people were using ET tubes to get just the chunks up, right? Those you could hook up to suction and do
Right.
better with. So it's there, right? And we've got to. I think that's
Hmm.
what education really builds, is that I have the propensity to do this. I'm smart enough to do this. I can jury rig this thing. And I think that next level is like, I can publish this. I can teach others about it. Here's a format. Here's why the science supports it. That's the whole package,
Yep.
right?
Now you got me thinking. Yeah. Thanks for that.
Absolutely.
Uh,
That's the other great part about it.
you had this casualty for 4 hours,
Mm-hmm.
and did you not run out of ketamine, or do you just have an absolute ton of stuff in your ambulances?
I'm super lucky that we have an amazing medical director, um, who really believes in paramedics. So our normal drug loadout in terms of analgesics and sedatives, we've got a gram of ketamine, 400 of fentanyl, 5 of Dilaudid, and 10 of morphine, Versed,
Hmm.
and Ativan. So I've got some stuff to work with, right? And we initially, she got some fentanyl, and then we ended up doing some Dilaudid with her because it just wasn't touching her. So over that, if you kind of space things out, we were doing okay. We didn't quite start going into the ketamine world. We do ketamine for pain. We were saving it, um, to, in case we had to intubate her, because it's kind of our induction agent of choice. So we were
Hmm.
okay. We were able to do some push doses, and then, after the first 2 or 3 push doses, that's when we're like, oh man, where does this go from here? So we still had enough with her pain management, kind of what she needed, uh, to have gone further. And then once the aircraft got there was obviously more. And part of that is always thinking, what's next, right? One of the new paramedics with our group who just came to us from Alaska, he's great. And he's like, well, when would we have, made the switch and intubated ourselves? And we had a great discussion about that. And I think it's always looking forward. Push doses are easy. She needed more than anything is kind of some sedation versus pain management. You could tell when pain management was working, but the moment it kind of wore off, she went from a somnolent pain managed person to, the combative fallen head injury. And so benzos were a thing. And you just kind of have to make a plan early on before you find yourself too deep. So we didn't run out. We were doing okay. Um, and I think that just is a testament to my crews who think ahead. They just don't go hard, go fast unless they know they can, because, the hospital's closed or there's a quick extrication plan or extraction plan. Uh, the guys on that truck were already thinking we may have to drive all the way to the closest trauma center 2 hours away from here, you know. And so we've got to start thinking that way.
Hmm.
And the other thing we do is build into the culture when they go, hey, captain or shift supervisor, things have not gone well. Can you bring the other drug box up? So we've got an extra drug box ready to go. We've got a specific back
Nice.
country drug box ready to go. Um, and it's hard to build the catch-all for every situation, but if we teach people concepts, right, and not cookbooks, we can think our way through things. And hey, we've got this IFT, or we've got this point of care that we're going to take to Montrose, which is our next closest bigger hospital. I'm going to run out of meds. Can you meet me with fentanyl infusion alongside of the road? Okay, yeah, let's make that happen.
Hmm.
It's the system management, right? We're doing everything we can not to play
Right.
catch up. We're going to push these resources to the call. If I don't need it, yeah, we have to do paperwork for controls and we have to throw a drug away maybe, but my mission is to do the best patient care where I can do it, when I can do it. And so we're lucky that I work for a hospital CEO and a chief that promotes that. Um, so pushing those
Hmm.
resources, what am I going to need down the road? um, is imperative to our success.
You're so remote that the mannitol in that situation wouldn't last very long at all. So, were you using hypertonic saline?
No, we're not there yet. We actually see a lot of hyponatremic people out here, and my chief has a big passion for it. So he was a park ranger and a SAR ranger in the Grand Canyon. So we see the folks that do not hydrate and provide for their nutrition well, who just have a lot of hyponatremia. So we're starting to do that on the hospital side, and we'll take that with us. We haven't quite hit it on the pre-hospital side, but it's part of the long list that I like to make my medical director groan a little bit for all the right fun reasons for 2024. Um, and we're kind of in that, mixing it pre-hospital without that CAT scan and doing all that kind of stuff is like in this environment is like maybe yes, maybe no. We're doing it a lot for our IFTs from the hospital because we're just seeing a lot of hyponatremia, believe it or not.
Mm.
So for the head injury stuff, the Kepra is kind of the thing these days in our world, and I think we're probably going to start carrying it in the pre-hospital realm here shortly. Um, but we're not just quite there yet with it.
And you had ultrasound for measuring her ocular nerve sheath, correct?
I wish. That's also on the list. It is budgeted. We're going to do it. We
Ah,
actually talked about it. So one of the things we do with our after actions is like what would have made a better outcome, would have changed things, and I think ultrasound for us, doesn't it is not the best thing ever in the world. There's amazing things you can do with it. And so my big use as we're developing our program here is when to go to the other hospital and move to the next echelon, right? So instead of being like, I'm not sure what's wrong with this patient, they should just go to the local hospital. If you've got a grossly positive fast, maybe you should go straight to the surgeon. And
mm,
our surgeons are great, but that's not the surgery they like to do. And so that's going to see our big thing. But there's tons of utility, right? You can look at that ocular nerve sheath. I can look
mm,
at, does she have those other, um, you know, how do her lungs look? What does her hydration status look like? When we're with these patients a long time,
indeed.
like the guess
Yeah.
of I'm just going to throw saline or ringers at them until they pee or have pulmonary edema, like we can do better than that, right? Um, we
Indeed.
do have
Yeah.
point of care lab testing, and so we've got one unit right now. So
Good.
it's like remember to bring the Epoch with you, and it's new. So it's remember to bring it with you and understand its limitations. So we can do a chemistry and a VBG or a capillary ABG with it, and that's like game changing, right? I'm side of the road of the
Yeah,
highway, no,
definitely.
no middle nowhere America or up the back country, but you've got to balance that toy, for lack of better terms, with am I going to carry this big dry box with it in it?
And the nice thing about the Epoch is you don't have to refrigerate the cartridges like you do with the iStat.
Yeah, it's way more user friendly than the iStat. I had used the iStat when I was working as a community paramedic here in Colorado, and I was like, man, this is a pain in the butt. That little bubble, great
Mm,
device, right? It brings things that we did not have to the field, but the user interface on the Epoch is just a little bit more dialed in. And we were able
yeah,
to work with our
indeed.
lab like we did with the blood and do this thing that a lot of people aren't. And under the critical care endorsement here in Colorado, you can do pre-hospital labs. Um, and
Nice.
so we're doing that more and more because we sometimes have a 3.5 hour, 4 hour vent patient. We don't do it a lot either. So we get stuck in this world where you get the sickest patient when the weather's the worst and flights are down. And now we're going to go to Denver, which is about 225 miles away through the mountains. Um,
Oof.
it's it
Yeah.
is challenging. We had a young lady last year fall off a ski lift who was having neuro issues, basically nipple line down. She was paralyzed, had a little bit of movement, and was going into neurogenic shock and couldn't keep her pressure up. She was spiking a temp with it and everything. And we had the Mr. Toad's Wild Ride, 4.5 hours, 5 hours. I think it was 6 by the end when we finally got there to Denver Children's.
Wow.
Um, it's some of the worst snow I've ever saw. Our teammate who was driving, having a good driver. It's again doesn't sound sexy, but man, that's like the most important thing because if I can't get where I need to go, and our team members understand that. I say it all the time, guys. You're the most important thing here. All my drugs in the back are for naught if I don't get where I need to go. Um, and the passes were awful, and we managed there, and we got up there, and they'd been waiting for us forever. So there's literally 100 people in that trauma bay, and that's
Wow.
uniquely the pre-hospital experience, right? You walk into there, whether you're a flight nurse or paramedic, and you got to give the big room talk, and you're like, here's what we did over the last. They're like, you gave how much medicine, and you did how much ketamine, and we're like, and they were, where's the doctor or the nurse came with you, and we're like, they didn't, and so
Yeah.
it's hard to build for that event and plan for it, right? These are not totally low frequency, they're not high frequency, and you don't get to choose who's working that day for the crew. So I think it's really culture. Slow down, think about this call. What tools do we have? What devices do we have? What can we bring in? Do we need to call a snowplow? That's a seat. Sometimes you're like, hey, CDOT, I need to get over the pass. Can you help me? I know it's closed, but I got to get this person out. Balanced with patients at the hospital has very solid reasons that they want to send out, and we're like, they're going to wait till morning because my staff is tired or the weather's bad. Those are hard discussions to have, but I think those play into what looks like a simple hospital transfer, but because of a remoteness and the environmental factors at play and the distance and time in the ambulance, those kind of play into what does a larger medevac look like or a casevac, because it's not just down the road to suburban tertiary care center.
So, Nick, my last question for you, mate. What advice do you have for a newly qualified remote medic as she's just starting out on her career?
Be curious. You don't know everything, and so when you find something, look it up. When you have, the classic, if you figure out patients, I have this disease, I have this pathology, look it up, figure it out. You don't have to have the answer like right then sometimes, but you're building that knowledge piece by piece, and get out of your comfort zone, meet people you don't know. That's why we're coming to see you guys here at your conference in February, which
Yeah, a
I'm
couple of
super
weeks, a
excited
fortnight.
about.
Yeah.
Yeah, and
Yeah.
there's people there that I've never interacted with before. Be open. As a remote paramedic, you can learn a lot from a dentist, right? As a remote paramedic, you can learn a lot from a logistics supply person, and build your mental model. I'm a huge OODA loop guy, and I think having to slow down and think about what you're doing and really making a plan and being open to being wrong, those couple of tools as a new remote provider or any level provider for that matter, will set people up for success. And I say that from learning the hard way, right? Learn from our mistakes out here because we've made them. We've been there tired and
Yeah.
scared and not having answers, and you've got this sick patient, you got to move them forward. And it's like, man, if I really understood that the locals I was working with have a really good tractor and a trailer, I could have moved this patient. Because, thinking beyond the ambulance and beyond those things, trust your locals know that environment better than you ever will. I learned that with the Belizean commandos. Those guys were amazing. They would just disappear in the jungle, and I shouldn't be telling them anything about the jungle. I need to listen and learn because they know everything about it. I grew up in DC. I know a lot about embassies and metros, but I know nothing about the jungle until I just really got quiet and was open to that. So be curious, have a mental model, network with people. I think those are huge as a new provider.
I like that. Nick, thanks for your time today.
Absolutely. Thanks for having me. It's my pleasure.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.